Good morning or good afternoon. This is Dr. Tomas Silber speaking, and introduce myself. I'm the medical director of the Eating Disorders Program of the Division of Adolescent and Young Adult Medicine, and we have our program located at our Friendship Heights satellite.
My name is Patricia Kapunan. I'm one of the adolescent medicine specialists here at Children's, and I'm also one of the eating disorder clinicians at Delaney Outpatient Eating Disorder Center with Dr. Silber. Here at Children's, we also have an inpatient service where we do nutritional rehabilitation admissions for eating disorders, so I will often encounter your patients both in the inpatient acute setting as well as in our outpatient clinic. I also I see some people have come who were at Future of Pediatrics where we gave sort of a more basic talk about practical eating disorder management, and this is a follow-up to that presentation. So without further ado, we'll go ahead and get started. So eating disorders are typically serious and chronic disorders, and they often present to primary care providers as pediatricians or pediatric providers. Growth is something that's very important to us. So often, eating disorders are something that you may be suspicious of fairly early in the course, or you may encounter farther along the course. Care occurs along a broad spectrum, and the standard of care is by a multidisciplinary team, including medical specialists, therapists, psychiatrists, dietitians, and sometimes other consultants. Family-based treatment is a standard in eating disorders care right now, and it's very effective. It's different than family-based treatment. It's different than family therapy, and we'll talk a little bit more about it. So, unfortunately, even though an FBT therapist is an important member of the multidisciplinary team, they're not often available, and patients may miss out on this important treatment for a variety of reasons. Sometimes they simply don't live near an area where family-based treatment therapists are available, and we sometimes encounter situations in which insurance is unwilling to pay for this therapy. When we do have access to service, for example, here in the DMV, where especially close to the capital area, there are FBT-trained therapists, there may be long waiting lists. So this begs the question, if FBT is an emerging and evidence-based therapy for eating disorders, what do you do in the situation where you can't find a trained therapist? Is this something that we can do ourselves? So just as a brief review, there are some important concepts that have involved in a pediatric eating disorder management. The very first one that I think it's important to review is nutrition first. So sort of in the old days, we would think this is a disorder that belongs to our psychiatric colleagues, and doing intense behavioral intervention to address eating disorder thoughts was previously the priority. Now, we take a different approach, and we set nutritional recovery as the precondition for any further psychological recovery that will sustain gains in the long term. So simply providing nutrition as medicine in the inpatient acute setting, nutrition is the emergency medicine, is the very first step. So counteracting the effects of severe and dangerous malnutrition is the first step in eating disorder treatment. Family-based treatment is the current standard, which explains some of our great outcomes in pediatrics. Children come with parents, caregivers who can support and guide their weight restoration journey. This employs an agnostic approach to remove, blame, and externalize the disorder, and we'll talk more about how these principles are important and set up for success when managing pediatric eating disorders. So family-based treatment in its purest form was developed by Locke and Lagrange at Maudsley in England. It is deployed traditionally by a trained clinician who provides the therapy over 15 to 20 sessions according to a strict curriculum. The main focus is that parents are the solution to nutritional recovery and not the problem. So parent-guided, parent-led nutrition is what sustains recovery over time. parents are encouraged to assume an active and primary role, so not just dropping their child off at the behavioral therapist so they can work on their eating disorder thoughts, but they really assume a lot more responsibility in being able to offer, sustain, monitor, and ensure nutrition at home in order to support the gradual improvement that we see in maladaptive eating behaviors. This is not the same as family therapy, and often we recommend family therapy as an adjunct, even when people are receiving family-based treatment from a trained clinician. To go back conceptually, that's how I explain it to parents, is there was a time in your child's life that we did not trust them to make their own independent decisions about food, correct? Like back when they were an infant or a toddler, we did not rely on their independence to choose when and what they wanted to eat. For a younger child, you are typically determining when the meal times happen, you're plating the food, you're offering the food, and you're providing close supervision to make sure that adequate nutrition happens. That's something natural that all parents do in early childhood. And the approach of family-based treatment is if we've gotten to a point where someone who was previously able to nourish themselves and was already progressing along a journey of independence, for some reason is no longer able to make those safe nutrition choices, parents will kind of dial back to the beginning and provide the support that they were used to giving and that they already know how to give, develop in a more developmentally early trajectory of the child's eating behavior journey, if that makes sense. And often what we see, this can be counterintuitive because many of the new patients we see are independent in so many other domains. They can be high achieving, they could be great at school, and they receive very little supervision or discipline about anything. Homework, they may be already preparing meals for the family, and it's a little bit of a conceptual jump to tell the family, you know, right now their choices are not safe. We need to kind of dial back to maybe where they once were and provide additional support for what used to be a simple behavior for which they had independence. So if you look at the normal developmental trajectory, a toddler will eat meals plated and prepared and supervised by parents. Eventually, an elementary school age child may be able to make their own plate from family choices at a dinner, and a parent might just supervise that they're taking some vegetables, finishing their food, eating enough for growth. As far as eating at lunch, you know, children in elementary school are supervised by some adults, and typically it's parents who are providing and selecting what the lunch items are. And as kids get older, they move into more and more unsupervised environments that assume that they are able to make more independent decisions about their food, and they might even begin to prepare meals, shop. Hopefully by the time that they leave the nest, they're independent in shopping and preparing their own meals in a way that allows them to meet their basic nutritional needs, right? Okay. So this is the basis of family-based treatment, supporting parents to provide a level of supervision and support that they already know how to do, but may be counterintuitive in an older kid, an independent kid who may be very sick, but which is absolutely necessary for their recovery. And it's the basis of the well-developed FBT curriculum. But if you don't have an FBT therapist, how do you do this? It may sound crazy when I tell you that people go to school and train to be FBT therapists, and they have, you know, 15 to 20 half-hour to 1-hour sessions to focus just on supporting parents, supporting nutrition at home. Because this approach has been successful, it has now been adopted in so many different ways. In fact, the success of FBT has become more difficult to understand because it now occurs in so many exciting variations. People have started to ask the question, do you need 15 sessions? Can you do 10 sessions? Can you do 5 sessions? Who needs to do it? You know, we have colleagues in the community who are trained as dietitians, psychologists, family therapists, individual therapists who have also started to train in FBT and incorporate that into their routine practice, but also doing some of the FBT work that they learned in their training. There are even models now of doing virtual FBT or FBT in the home with available family members. So FBT has been successful. It's difficult to study because it has undergone many variations, but these many variations are exciting because I feel that overall it makes it more accessible to families who desperately need this service. So for the next part of the talk, I'm going to invite Dr. Silber to talk about how we do physician-guided FBT at Delaney. Of course, this is going to be different than what you're going to be able to incorporate into a busy primary care schedule, but he's able to deploy this technique in a fairly systematic and successful way. So we will start by talking about how he does it in clinic, and then we'll start a discussion on how it might be deployed in a more primary care setting. Okay, so I'll hand it over to Dr. Silber.
Well, I just realized that as I go on with this presentation, I may get myself out of a job because what I do, any pediatrician can do when they have a good relationship with the family. The justification for physician-guided family treatment is not only the absence of an available therapist, it is the urgency of intervening when you have a starving little kid. You have to do something right then and there, even for an appointment that will be a week from now or 2 weeks from now. Why? FBT is congruent with the traditional pediatric skills for delivering anticipatory guidance, providing psychoeducational counseling, and incorporating caregivers as critical treatment team members. And there's another factor. For those patients that have a more severe form, sometimes there is a treatment fatigue. The family is dissatisfied. They drop out of whatever therapy they're in. Anorexia nervosa has the highest dropout rate of all psychiatric treatments. But families tend to sustain relationship with their pediatrician, even if they abandon other caretakers. So that's a strong reason to be available to them. The most important thing is that we pediatricians provide support in a non-blaming context. We have known them for so long. Target specific changes early on the eating disorder-related behavior is what is so important, very early on. There are some studies that show that if there's a rapid weight recovery at the beginning of the treatment, the prognosis is very good. So it's a matter of timing. One reinforces the eating disorder services by doing this, and in a way, we advance what other members of the multidisciplinary team are trying to do. And more than anything, it promotes hope from a trusted source. A typical thing that I tell my patients, for instance, is clinically, there's a big difference between anorexia nervosa in adults and anorexia nervosa in children. And really, taking an example from some other life event, you'll understand that right away. If adolescent kids, boys usually, meet in the bathroom, exposed to each other, see who can urinate the further, and so on, we'll just roll our eyes and say, boys will be boys. But if a 30-year-old man does the same thing, we surely would be tremendously alarmed. And that is really a marked difference between the disease in pediatrics than in adults. Now, the initial visit that we have is exactly what you always do in the office, you know. You get anthropometrics, you get the vital signs, you do the physical, you obtain your labs, and you make a decision, and we can help with that, whether hospitalization is indicated. You know, if the patient is bradycardic, if the patient is orthostatic, if the patient has stopped eating, all those reasons, we can work on. If outpatient treatment is safe, the pediatrician then can recommend a treatment plan that really includes the first steps of FBT. Usually, to make this more successful, this is going to be a longer visit. Try to see this patient at the end of the day in the last slot. And it really helps if one can arrange that both parents be present at the time of this evaluation. As I said, this is all adapted from classical FBT. Very important, sometimes families come in with denial. You know, I had, for instance, a child of two physicians that came in 2 standard deviations before from her weight, was acrocyanotic, was hypothermic, had lanugo, very worrisome. And the parents, didn't really see it because this took place over time. So in that moment, if that happens, one has to create anxiety about the condition. In other words, while we usually try to reassure people, if people don't understand what's going on, you really have to alarm them so that they feel they have to do an intervention. It's important to listen from the parents their thoughts about anorexia nervosa once you comment that you suspect this is the case. Many parents feel guilty and think that they are the cause, and they or look for something else. They ask very often to look for the cause, and that wastes precious time. It's really multifactorial. You know, the same way I tell them, look, if somebody has a heart attack, why the heart attack? Well, usually it's more common in middle-aged males that have are balding, have hair in their ears, have high blood pressure, have high cholesterol, are smoking, are sedentary, and so on and so on and so on. And it's no different with anorexia. Very often there's a genetic background in which you have family history of eating disorders, of anxiety, of mood disorders, of substance abuse, of alcoholism, and they're all predisposing factors. And one that's very important is perfectionism. And at that point, you pass the one cause and you start externalizing the illness. And what I tell the parents is you have to learn when your daughter speaks and when anorexia talks. So requests that the kids make that are reasonable, perhaps she would like to have her ears pierced, to wear some jewelry or things like that, sure, you talk with her. But when she's making the decision to be a vegan, that's anorexia talking, and one needs to not allow that. And then parents are always very anxious about getting immediately treatment that will address the psychological issue. Actually, many of the most effective family-based therapists forbid the family to discuss any psychological aspect of any kind. It's not allowed. And what is the whole point is that the center of the activity is weight recovery. And so I often have psychologists that are not familiar with this, with whom I work, and they tell me the patient is making progress. And then I look at the scale and the patient has lost weight. There's no such thing as making psychological progress if you're losing weight. So weight normalization is a precondition to psychological improvement. And so how do we do that? We have to empower the parents. I usually ask them to tell me, and this is a very embarrassing question, I tell them, tell me what you're good at, what you have been noticed for, really distinguished yourself. And, you know, people have a variety of things that they do. And so I empower them. And there's a dictum, the parents are not the problem, they are the solution that we have to follow. There are some obstacles to recovery. If the patients feel guilty, they're paralyzed because they'll let the kid do things. They're sorry for the kid and they'll let the diet to continue. Blaming is an obstacle to recovery too. And so when we have a very critical parent, the Maudsley or FBT very much recommends to at that time leave the kid out of the therapy and work with the critical parent to change that approach. And of course, one has to explore the support system. If there are siblings, ensure that they're not parentified. They have to be enlisted as a support to the patient. Parents should not allow them to take that role. The kid, other siblings are not allowed to say, you have to eat more, whatever. The parents should firmly interdict that. And instead, when the kid gets sad and upset because of the parental demands, the siblings can take the role of a comrade, of inviting them to the movies or whatever, right? One of the things that sometimes complicates the treatment is you're often not dealing with one condition, and especially older adolescents, you already see that they have an anxiety disorder or depressive disorder or alcohol substance abuse problems, and of course that has to be treated and referred to mental health. Often the initial depression may be nutritional. And when food comes in and weight is recovered, the depression begins to lift. But the comorbidity is real. And of course, when the nutrition improves, medication, SSRIs can be helpful. They don't improve the anorexia. They have no impact on the anorexia. But they certainly improve the comorbidity, which makes it easier to treat the eating disorder. Of interest, in some studies that they've done, Walter Kay has noticed that patients who have anxiety disorder, when they restrict their food and marked restriction, the anxiety begins to improve and sometimes even disappears. So there may be some kind of mechanism related to that in the eating disorders. So, in the subsequent visits, they can be just half hour, sometimes they can even be 15 minutes visits if the child is well. You do again the anthropometrics, you review with the parents what they've done. If the parent is now finally receiving FBT, you just reinforce that that's fine. If the parents complain, we haven't discussed any psychological issue, no, you cannot do that until the nutrition has really improved. At least one session, the pediatrician should incorporate the siblings because some of them are frightened. And I heard more than one time, I think my sister's going to die, and you can help them. And we really want the parents to be proactive. And so I tell them often, I know the illness, you know your child, and they come up with good ideas. So at least early on, the focus is entirely on weight recovery through problem solving. A common situation is I write notes for the school, allowing the parents to take the kid out of school so they can supervise the important lunch meal. Now, of course, what we pediatricians can do is really FBT without a therapist, and so it's different. For instance, the classical FBT therapist involves a family meal where the therapist observes the family and encourages interactions that will already at that visit improve the child's eating. It includes a physical assessment, which the FBT therapists don't do. They rely on us. We often see parents and children separately, and many of our visits take place with only one parent present. And if we're lucky, the other parent participates on speakerphone. So these are all variants. Some people might call them heresies, but as long as you do the main approach, it really helps.
I'm going to start the discussion on potential barriers for physician-led FBT. Again, at our outpatient eating disorder center, we have 60-minute intakes and more time to spend with families on this type of work. I will say that I have done this in primary care practice, this was before I came to Children's, and I moved to the DMV as a pediatrician and was startled by how much of it I saw compared to my prior practice in Texas. So as far as training, I did most of that on my own. I had the benefit of being able to email Dr. Silber in times of great extremis about patients who I was having a difficult time with, but I literally got my hands on everything Maudsley I could read. I happened to have a nutritionist in my practice, and the two of us together started doing this type of physician-guided FBT therapy. Our initial visit, I would cover all 10, probably over the course of 2 to 3 visits. And in my Future of Peds presentation, I talked about doing the initial medical assessment to ensure stability for outpatient and to make sure that someone did not need to be acutely admitted, followed by a short follow-up, like maybe 48 to 72 hours, during which the family can trial a really simple nutrition plan, like stop rowing crew, have an extra boost, and that would also give you a lot more information to continue to talk about those 10 initial visit steps. So I found in my prior primary care practice, I was able to do a lot of these 10 steps over the course of 2 or 3 visits, which I would cluster over, about a week, maybe a week and a half when I was first getting to know a patient. So it takes time, but this is something, if you can ensure clinical stability, can happen over the course of several visits. And billing is always going to remain a challenge. And one thing we're experimenting here now is how do we build the tremendous amount of care coordination that comes with these patients, because we are prioritizing working with primary care providers and other network community providers who become part of the treatment team. And I think these are the basic challenges. The other challenge that I would mention is some families are not ready for family-based treatment, and that's a really important assessment, and part of the reason I really encourage an early follow-up with a small trial of how well the parents will do about enforcing even a small nutritional change. There are so many complexities to family dynamics. Not everybody has 2 parents. Not everybody has parents who are able at that time to engage in the significant work of FBT. So whether or not families are able to do it, I think is a really important question. Sometimes we have children who are less sick, but whose families really are struggling with being able to support them in any way, and we might not try outpatient FBT type therapy for them at the onset. Did you have any other thoughts about challenges to FBT besides what we just talked about, Dr. Silber?
Well, yes. The main challenge is the vision that families have about how a child ought to be treated. There are some families, I see a lot of children of physicians, psychologists, and so on, that have the idea that you should not interfere with the child's development, that she on her own, or he, will realize in treatment what it is that they have to do, and that they should be the ones choosing their meals and getting better. It's a philosophical issue, and in general, it's a good position to be at. But anorexia nervosa is a mental illness, and you cannot treat a child with a mental illness the same way that you treat an adolescent who doesn't have one. And so that may be often a difficulty. Parents that are more, authoritative and are accustomed to taking charge about things, making sure that they know what the kids are watching on the internet, what time is the curfew, and those type of things, they are the best candidates for FBT. And usually the authoritative, as opposed to authoritarian, have the skill of directing without offending, and actually being encouraging at the time that they're setting limits to the anorexia. For instance, not allowing the kid in the kitchen, not allowing the kid to cook, and those type of things.
Excellent. And the other thing we didn't mention when we were talking about the nutrition-first approach is that we know a lot about the effects of malnutrition on the brain. So this type of reasoning and independence and leeway, offering that opportunity to the malnourished brain that is also suffering from eating disordered, very rigid eating disordered thoughts, you're not going to make much headway with that approach until some nutritional recovery is underway for someone who's moderately or severely malnourished.
And that's very important. There is a particular clinical situation in the malnourished brain, which is referred to as the organic brain syndrome. And this occurs where the child that you interview, it has a latency time before they answer. When they answer in a monotonous way, inflections are gone, and it's not passive aggression, it's not rejection of the pediatrician, it's just that brain at that moment is really working on ketones. And of course, that's another indication for hospitalization, because when the brain is in that situation, there's not much you can do.
So if all this sounds very overwhelming, I'd like to talk about FBT Light. Like, if you don't feel that being the primary person supporting a family-based treatment approach, owning the nutrition plan, and walking and supporting parents through the nutrition plan, treatment of anorexia nervosa and related eating disorders should always be as part of a team, and primary care providers can continue to be part of the team. And if you know how to just reinforce FBT principles, that helps everybody on the team, and it's also really effective in addressing early concerning behaviors that may be leading to the development of restrictive or other eating disorders. I explain these core principles even when someone comes in to the hospital for acute stabilization. Oftentimes, that is the first introduction that many of the families we have to their child's eating disorder, and on the very first or second day of the admission, even though we're not going to be doing family-based treatment, even though we are probably going to be discharging to a more restrictive treatment environment for someone who is sick enough to end up in the hospital, it's important to kind of lay out what the eventual role parents can play, what the ideal role, I think, that parents will be able to play, because the nutritional stabilization that we do up front, the intensive inpatient and residential work that we do, just provides the basis for what's going to be an ongoing relationship around eating and food, because most of the nutritional, psychological, and physiologic recovery is going to extend and continue for months after you leave these therapeutic milieus. So the very first principle that we've already talked about is nutrition first, right? We can talk about the thoughts. Psychological intervention becomes a part of therapy, but the first thing I need to do is save your life if you're in the hospital through emergency medicine, and the medicine is nutrition. Or if we're worried about the signs and symptoms of malnutrition that you're having, we can continue to ask all those other questions you have while addressing your nutrition first. That will get your brain in the right place, and that will physiologically stabilize us to a safe place where we can address the rest of what's going on. I enforce that parents are the solution, not the problem. It is your team effort as a family that is really going to save your child's life. I'm here to help. I'm here to stabilize. We're going to offer resources and build your team, but parents are critical members of the team and the ones who are going to be the most important going forward. The agnostic approach refers to, we're not going to waste time early on the why, right? The why at the beginning, we need to rule out contributing organic medical etiologies that may need to be separately addressed, but a lot of people are very focused on, you know, how did we get here? What's going on? Is there something that we're missing? But we don't need to answer those questions to move towards nutritional recovery. The treatment for malnutrition, no matter how you got there, is the same. The parent's role in supporting nutrition for someone who's not eating for whatever reason is the same. So early on, we take an agnostic approach, and the treatment occurs regardless of the whys. Removing blame is critically important. You wouldn't blame your child for having diabetes, and you wouldn't blame yourself for your child needing insulin to survive. But this becomes an enormous obstacle in going forward with treatment. The idea that the child and not the anorexia is driving all the choices, or the blame that caregivers can engage in, not just of the children, but of themselves and each other. These are all things that are critical to address, but it's important to name them for what they are in the beginning so people can move forward with the most beneficial parts of therapy. Externalizing the disorder is very helpful. Seeing your child for who they are, someone in the grips of a severe illness, is really important. Know when your child's talking and when the anorexia is talking. That can be very difficult to do, but if you give someone that concept that these behaviors are not your child's, there's something in their brain that has taken over their decision making, that can be really helpful in how they respond to and support their children in their eating. Some other things that we talk about really early on. Eating disorders are a marathon, not a sprint. You're 5 to 7 days in the hospital. You're 4 weeks in inpatient. That is not going to solve all the problems that got you here in the vast majority of cases. So prepare for a long journey. I often say you're facing the right direction on a very difficult road, but let's be honest about our energy and resources. Oftentimes people come in the hospital and they're reluctant to engage in a higher level of care. Or we meet someone for an intake and we recommend intensive outpatient therapy, and they're reluctant to engage in a higher level of care because it's a new diagnosis and it's a big change. But if you throw your azimuth out and think this is something that's going to take months and not weeks, then you can kind of budget your energy as a family to prioritize more intensive treatment up front while you can get all your ducks in line to prepare for something like family-based treatment, which becomes labor-intensive and exhausting. I talk about how caregivers should present a unified front. Fake it till you make it, right? Be confident about the plan. It is very difficult to see your child suffering, and the harder you fight anorexia, the harder it fights back. So it is sometimes really tempting to give in to the anorexia when it's yelling back at you. And it's important, especially at meal times, for caregivers to express confidence and a unified front, not just with each other, but with the treatment team. I often talk to parents about having kind of an on-stage and off-stage concept where if there's anything that we're doing as a treatment team that you're uncertain about it, let's talk about that as a treatment team, but then let's get on the same page so we can really enforce and be confident with a treatment plan, especially at the critical times, which are meals. Model distress tolerance while acknowledging how distressing it is to see your child upset. It is very difficult to coach parents to be both kind and firm, but this is exactly what Dr. Silber was talking about. Parents who have developed a more authoritative style may come more naturally to being authoritative, but also be active listeners and be kind in how they mete out discipline. And then be aware of treatment fatigue. I think as pediatricians, that's something that is so important for us. We support parents, and sometimes we ask them to do things in treatment that might just be beyond. This is a marathon, and understanding when people are just simply too tired and need an extra level of help, or that they're going to go in and out of how well that they do at FBT, that there's going to be ups and there's going to be downs, but then there will be ups again. This is a really important long-term view to support parents while you're kind of screening them for how they're doing. And any logistical support you can provide. I often write letters for FMLA. We try to time appointments at a time that's going to be maximize parent participation in care. So all these really practical steps that limit barriers to care for families turn out to be critically important. So in conclusion, physician-implemented FBT is a thing. We think that in the absence of an FBT therapist, this can be done and done successfully. It can be done on its own. It can be done as a complement to other treatment modalities. All of us at Delaney, even when we have an FBT therapist in our team, are doing a little FBT, right, in the course of our conversations with parents in our primary roles. At the very core of this intervention are putting parents in charge, externalizing the illness, and eliminating guilt. So when we ask you to do physician-led FBT or to really enforce FBT principles in your practice for patients who are already in care with other treatment team members, it doesn't mean ever that you're doing it alone. It means that you're reinforcing the principles that have been found to be successful and currently standard in our field. Model confidence. If you have questions, you can always call us. And again, reinforcing FBT principles can be employed to support families when they're receiving care elsewhere. We are always happy to help. I've been honestly very impressed with the amount of eating disorder management that I have encountered in the community here in the DMV. I think a lot of people are doing a lot more here than they do elsewhere in the country, and we get a whole range of referrals in terms of folks who are uncomfortable doing any kind of management, folks who have done a lot of it themselves and they have a specific question like, when can I return this kid back to sports, or am I doing this right? We're doing everything in the book, but they're not gaining weight fast enough. So we're happy to support and meet you wherever you're at. And again, parents are not to blame. This is a very difficult and chronic disorder. When people don't succeed, parents are not to blame, the child is not to blame, and the caregivers, including the providers, should also recognize that this is a difficult disorder, and sometimes, despite your best efforts, kids will have downs before they have ups. All right, so we have some references. I'm being reminded that we did not just mention our disclosures up front. I do not have any financial disclosures, Dr. Silber.
None.
Okay. And now we will open it for questions.